thank you so much, and thank you very much for this wonderful, very, very warm welcome, or shall I say cold welcome, actually. Guys, if you invite me, please give me a warning next time. You know, it is snowing outside. I come from spring into winter, back into Christmas, wonderful Christmas snowing. But thanks very much for your very, very warm welcome. I'm absolutely delighted to be here today, and I'm going to tell you a bit about how we're approaching the issues around hospital and reorganization in England, of course. But before I do, I'm going to tell you a bit about myself, and I think I just press this button and then it moves. Yes, it moves magically. Great. So I'm Professor in Health Services Research. We have a medical school in Lancashire that's just outside Liverpool, where I'm professor there, and also have various international and national roles, of course, with NHS England and in Brussels. But I'm also a governor of a hospital, in fact, so I have insight into the normal doings and froings in the hospital, but I'm also an academic, of course, and I also run a company where we're actually doing support, implementation support for hospital organizations and others. And when they're trying to change practices, that could be nursing practices, but could be clinical practices, but also organizational practices. So a broad kind of range of skills and broad kind of range of experience, really. Okay, we do have something like a poll. So I think if you guys have something on your mobile phone or so. It's a very simple question, don't worry. I'm not going to ask something complicated. But I want to talk to you about three things today. First of all, I would like to tell you a bit more about the trends, and you're aware of the trends, of course, so there's no real surprise there. But then I want to tell you a bit how we are addressing these trends and what are the challenges in England and what are the difficulties and how we are addressing these. And also, of course, we want to talk briefly about healthcare reforms. You guys have just undertaken one of the most significant reorganizations, and I think you struggled to get this through Parliament again and again and again, and probably after a while you thought, oh, hopefully it doesn't go through, but it did go through in the end, and now you're here. I can tell you, we have one of these reorganizations every 10 years, and it's not pleasant, of course. It is a huge undertaking, but maybe we can learn from each other, and I'm really keen to hear more from you later on. Okay, I think there is a poll somewhere, yeah? Let's see. Will there be fewer or more hospitals in Phineas in 10 years? Fewer, 80%, 20% of you saying more, but fewer, 80%. So it's a significant majority of you think. And of course, that's been the trend for a long time. Thank you so much. That's been a trend for a long time. The hospital beds have shrunk enormously. And why are we seeing this reduction in hospital beds? Well, it's very simple. It's efficiency. Now, looking back to the COVID pandemic, those health services with fewer beds were, of course, performing worse than those with more beds, with an excess capacity in beds, simply because they had more ready to go at a click of a button. So Germany, for example, has quite a huge excess capacity in beds, in hospital beds. The UK has practically nothing. We have about 93% of all our hospital beds are actually taken at any point in time. So there's very, very little excess capacity in the system. And of course, if you get a wave of infections in the community, 7% or 6% is not a lot, you know. So we are really struggling. But the drive to efficiency and optimizing the existing resources has of course meant that we are reducing hospital beds again and again. And also we are trying, of course, and as you are as well doing, we're trying to move the health services into the community. Fascinatingly, what we have seen in England is a reorganization of the community services in such a way that hospitals, which are independent, autonomous organizations, just like here, they have actually expanded into the community, swallowed some of the community organizations up, and then after a while, after about a year, said, well, why do we actually have to send our clinicians into the community? Let's just provide all the services in the hospital. So we have seen nominally a integration of community services and hospital services, but in fact many of the hospitals, many of the community services have then been relocated sometimes into the hospitals. That wasn't the purpose of the thing. That wasn't really what we're trying to achieve. We wanted to actually get clinicians out, some of the services out of the hospitals. Why is there such a drive to integrate, but at the same time actually to merge within hospital services, many of the community services? Simply, again, it's efficiency. If you are asking a clinician to, on a Thursday afternoon, to go into the community, that's additional resources. It's additional capital investment. All of these things are actually making it quite difficult for hospitals and organizations to maintain a presence in the community. It's easier to do this in a hospital. And you guys have to watch out when you've done this reform now. You have to think about, well, not just what is the structural reorganization, but also what are the trends of use? What are the utilization trends? Do they still provide sufficient and even more services in the community, or are they actually arrogating this back into hospital? Okay, I want to talk briefly about the hub and spoke model, because one of the hub and spoke models, this is the last one there, one of the hub and spoke models in the UK has become quite popular over the last 10 years, really. It's been with us for a while. And I wanted to give you, just for 2 minutes, I want to talk to you about this wonderful example, neurologist telemedicine network. I was involved in this as well. We evaluated it. And what it basically was, relatively simple, is it's a portal. It's a telemedicine portal. And in fact, what we have a specialist hospital, neurologist hospital, and when we have many district hospitals across the region. And what we wanted to do is we wanted to share the expertise that we have with our consultants, neurologist consultants in the specialist hospitals, with the neurologists who are sitting in the other hospitals. So we had a spoke and hub, as it were, the hub and the spoke. And what we tried to do is, well, if we have something like such a portal, why can't we take this to the bedside of a patient in a district general hospital, and they can then call the consultant in the neurologist specialist hospital, and they can talk about this case, and they can make a decision. So they're tapping into the expertise of that neurologist consultant in the specialist hospital through this portal. Wonderful idea, absolutely amazing idea. Well, it never worked. Why didn't it work? Well, very simply because consultants in the specialist hospitals were too busy. They couldn't try to arrange a common and a shared time at which 2 or 3 consultants can actually talk to each other in a very busy rota, in a very busy diary. It's almost impossible. Okay, so there's no flexibility in the system. But the other thing is also the consultants, the neurologist consultants in the spokes, i.e. in the district general hospitals, they were really against it. They really just didn't like that idea. Why? Because it seemed to indicate to them that they can't make a decision themselves. They need to consult somebody else, their colleague in the specialist hospital. And they actually thought this is really about de-skilling themselves, de-skilling them. It's not, they didn't see it as a shared learning exercise or sharing the learning across. They see it as de-skilling and an attack on their own expertise. So it was really, really difficult. And of course, eventually they thought this will lead to a reduced number of operations in the spoke hospitals. They thought a lot of these patients that are quite complicated, where we are communicating through this portal with the neurologist in the specialist hospital, many of these patients will then maybe, because they're so complicated, go to this specialist hospital, have to be referred. That means reduction in income and, crucially for consultants, reduction in skills. Okay, over time. They need those surgeries. They need that practice. Okay, so great idea, but in practice it actually looks quite more nuanced and quite tricky. Okay, I do want to talk about the changing needs. I told you as well, there's nothing on the slide that you don't know yet. As the chronic conditions, we have more long-term care in the community. We have multi-agency and professional collaborative care now. We're using the health population approach, of course, to shift our approaches in terms of health inequalities. In the UK, this is about commissioning. Again, there's a general shift from acute to preventative care, which sounds great, but it's actually quite complicated, and I know many of you know that. But I wanted to focus on something else, and that is just on multiple providers outside the conventional healthcare system. You may not experience this yet, or perhaps we hear from you later, but we experience this a lot in some generations. What do I mean by multiple providers outside the conventional healthcare system? So let's look at this. This is a very, very shocking number that we have had reported in the last year, in the last couple of months. 4 in 10 18 to 24-year-olds in Britain have used the private sector for things such as appointments with doctors, scans, and diagnostics. Now, let me just put this into context. The UK, the NHS England, provides 94% of all healthcare services in the UK. In England, in Wales and Scotland is 100%, and Northern Ireland is 100%. So in England alone, for 58 million people, we are looking at 94% of all health services provided by NHS England. So there's practically no private provision for the people in Britain. And that's a good thing or bad thing. You can discuss it, whatever you think about it. But the important thing to realize is, because you have a GP, a GP gatekeeper system, just similar to other health systems, everyone who is not registered with the GP will not be captured in the health system. Okay, so they won't have access to any other services. So if you don't actually register with your GP, for many different reasons, you won't have access to the hospital provision, to surgeries, diagnostics, etc., through the NHS. Okay. Now, that wasn't a problem when we didn't have online services. We didn't have Amazon Health, and we didn't have Bupa Health. These are private providers. They have crowded into that space with young people enormously. As you can see here, 4 in 10, that's 40%. 40% of people in that generation don't register with the GP anymore. And here's the difficulty. Why don't they do that? Well, because they're instantly available. You can actually arrange an appointment with a doctor or with a nurse, an advanced practitioner, within minutes, and by tomorrow they will see you. If you're trying to go through a normal NHS GP, I tried this recently, I'm still waiting for their call, you know? So it is actually extremely difficult. Young people don't have the time, they don't think about the sort of like all the ideological debates we talked about, private and public provider and all this. They don't care. They just do what they have to do. They need a solution to a problem. The problems are relatively minor. They're because you're young. They're not necessarily chronic conditions. So what they do, they go online, click on something, and they actually register with that, and they pay for this about £30. You know, it's a quick consultation. If there are additional things, prescriptions, they can get that online as well. So but what is the implication of this? This is really important. It means that we have no data on those 30% of the population in that generation. We have no health service and health utilization data. Amazon doesn't share that with us. And Bupa don't share the data with us as planners for the services. They don't tell us, you know, how many they've seen in the recent times and what they wear. So these are data that are lost. And of course, when you guys are now reorganizing your health and social care system, you brought data together from the health and social care, I think it was the Kanta system, and this is really important. But there will be a whole generation growing up that may actually drop out of the system altogether. How do you plan, commission, and design services for the future? It's a real serious problem. And one of the issues for this is, of course, at some point, these people will be back because they will develop chronic issues. They will be back and they will then drop into the system and then they will turn up. But it will be quite late in their lives. Okay, so these are the challenges we are experiencing at the moment, and some of these challenges might also crop up as you are planning things. Now, how do hospitals have addressed some of these challenges? Of course, we have workforce flexibility. We're thinking about advanced practitioners. We have actually quite a sustained and quite an enhanced program to upskill advanced practitioner and changing the roles. So we have nursing advanced practitioner nurses now. And we also driving, of course, population health management. This is data-driven segmentation, risk stratification, etc. And you know this all because it is done all across the world. Now, however, we also need to understand what makes our nurses and clinicians and medics actually tick, and how can we get them into continuous learning. And we talked about the telemedicine portal already early on. Now, the role of technology is absolutely crucial in this. It's telemedicine, it's data analytics, but also digital transformation. But I want to, I think this is actually the older PowerPoint. I think this is one of the older PowerPoints. Okay, fine, we're missing a slide, but actually what I wanted to talk to you about is what are the skills that are missing from our medics and from our nurses. And one of the things we noticed is, as you were in a hospital previously, you were generally, most of the time, in fact, sort of using management skills to manage your own team, to actually ensure that there's efficiency in the system, etc., and to assess and to evaluate. Now, as we are moving into a more integrated structure, what happens is that you're not looking at the normal hierarchy where management skills are really sufficient. You're now looking at networks, and an enormous amount of networks. And for that, those sort of navigating the networks of different providers and different organizations in the community, but also maybe within your hospital, requires different skills. So what NHS England asked us a couple of months ago, well, actually quite a few, maybe 6 months ago, is they asked us to look at the system leadership skills and what sort of like evidence is out there. And we noticed there isn't really any training. But in fact, sort of navigating networks of networks, and I had a wonderful graphic that will come to you if we send it out to everybody on the PowerPoint. The network of networks requires really different skills than a simple hierarchical structure, okay? And it's very important that we're getting that training into our clinical staff, into our managerial staff. Okay. Briefly, also structural versus organic reform. Risto talked about this, and before you ask me, I don't speak Finnish, but we talked about this PowerPoint previously, and so I have a bit of a clue what you talked about. And I do, of course, see again and again in England as well that we mostly have top-down reform. So we have top-down reorganization rather than, in fact, a bottom-up sort of like change. And the reason is relatively simple. Because we had, there's a wonderful study, by the way, looked at the effects of reorganization in England. So you can see how often we reorganized. You know, we reorganized a lot of times. But the effects on this, the global effects on this for the English population, have been negligible. There is really nothing you can see here, you know. So it's quite sad. There's a bit of mortality, but we're really not sure whether the mortality is just simply due to other factors, you know, the decrease in mortality. So there isn't really much to be seen here, and that's quite sad because obviously politicians put a lot of store and a lot of emphasis on reorganization. But why do we do it? or why do they do it? Well, very simple. This is one of those scientific papers on what political reforms in a system might mean. And you can see this is gobbledygook. I mean, this is just spaghetti, you know. And you can, why I put this up here, it's actually quite difficult to reform a health service or a health system in your case. And the difficulty means that whatever you're planning, whichever lever you pull, something else will happen at the other end. You know, it will never be what you're actually doing. And what you're actually trying. In a sector really with highly autonomous professionals and central government policymakers, there are very, very few levers that you can pull that will also produce the results that you want. Okay, there is something else, of course, you can do, and this is what we all do. We muddle through. And before you smile at this is actually a scientific approach. So Lindbohm is a beautiful, beautiful little paper. Lindbohm published that long time ago. And maybe it's worthwhile just having a quick look at that. This is actually how most organizations do that. They muddle through it to some extent. And it does work because you are closing the gaps or where the designers and those who are initiating reform, those gaps, they never thought of those gaps and those uncertainties, okay? But you are getting through this. Okay, now, I do want to take, as a good academic, you would expect me to go into the theory, and I want to satisfy your urgent request for some more theory as well. So I thought about what are the theoretical foundations really for all this restructuring and reorganization and for all the organizational changes. I come back again and again to the fundamental insights from structural theory, and that is there is no single best way to organize healthcare services. So whatever your reorganizational kind of like policymakers are trying to tell you, we have to do it this way or we have to do this that way. That's just simply not true. Every single hospital and everyone here in the room who is representing a hospital, you will find your own way, and you will have to find your own way. And that means you need to be able to deal with uncertainties, and you need to show an enormous amount of flexibility. Okay, what I do want to say, however, is we do know function follows form. And if that is the case, all the reorganizations that we've seen in England paid lip service to patient-centered care, but none of them did it. None of them, not a single design of that followed actually our reorganizations in 2012, 2013, or now in 2020 again. At 8 years later on, we reorganized some as well again, and none of them were actually sort of like designed to address patient-centered care. Okay, why is that? Well, there's many different reasons for that, but in effect, we still have hospitals and community services that are shaped around the clinical pathways. But not the clinic. It is actually more the clinical task rather than the clinical pathways, and that is just not good enough at this stage. So if you really want to have a patient-centered care system, we really need to look at where do the patients enter the system, where do the patients exit the system, and how can we make that a smooth transition and a smooth pathway. Okay. Towards a collaborative future, we all need to collaborate. I talked about system leadership, right? The requirements for system leadership. Yes, we need to share learning. In my publications, I always emphasized we need to be more comfortable with risk. When I walk into my hospital for a quality control visit, for example, in the night, what I see is my clinical colleagues talk to me and say, yes, we address this patient safety risk, we address this patient safety risk. That's all fine, that's great, that's wonderful. But we have a too strong focus to the exclusion of anything else on quality control and patient safety. Okay, I understand that is the first priority, that's the absolute priority for everyone, that the patients are safe. but that must not come to the exclusion, at the exclusion of anything else. For example, patient care, quality of patient care. So they rather mollycoddle the patient and kind of like don't expose the patient to any questions or any choices, because that could open up a real kind of difficult discussion around, are you going to be safe? How can we safeguard you, etc., etc. So we need a more risk-tolerating culture in our hospitals, but also in our community services. Okay, I have a little green light down here. It stays. I still have 1 more minute, so I do want to just briefly talk about. You can get in touch, of course. In the other PowerPoint, of course, I did have a couple of links to the publications we done recently. There is a publication out there. I was very privileged to publish that with my colleagues, European colleagues, on integrated care. It's a handbook, how to deliver integrated care. Check it out. It's a tiny little handbook. It's really great. It's become quite popular with our American colleagues. And it basically tells you what you need to do. It's a very practical, hands-on one. And then last year, I published something. You would expect me to do these cheap plugs for my books. There was a publication on integrated care. My reflections on this, critical reflections. I think we're using integrated care and care integration and integration of systems and hospitals with community services far too loosely and far too often. What we actually need to focus is simply on patient-centered care. And I say that as an editor of the Journal for Integrated Care. So it's in my heart, of course, but I think we need to come back really to the most important question is, does it benefit the patients if you're reorganizing these things and if you're reshaping our services? Okay, there we are. Okay, thank you so much for listening. I'm sorry, Kiitos.
Thank you so much. Thank you so much, Axel, for this great presentation. And I have a couple of questions, and the first one is being a little silly, I admit. I ask you to watch your personal crystal ball and imagine taking a visit to hospital 2050. From a patient's point of view, how is it going to be? What has changed?
Yeah, it's a great question. It's not a silly question at all, so it's great. And I think Risto, if I understand it correctly, talked a bit about this. It's about loosening the boundaries of the hospital. This is incredibly important. At the moment, all our financial governance structures, everything is really structured around a very fixed boundary of a hospital institution, as it were. And the same with community services, funding, everything is sort of like stops at the boundary. That's not going to work in the future. We have to find more flexible ways of working, and that means not just for you and for hospital managers and clinicians, but also for governance, for funding, for resource allocation. We need to be able to move people and resources from hospitals into community and back where needed. Okay? Otherwise, we will not meet the challenge of preventative services at some point. And at this moment in time in England, we are dead focused on acute care. That's about it. And I know many of you probably heard the figure. We've got 7 million, more than 7 million people waiting in England for hospital appointments. And of course, we need to get them out. Some of them have been waiting for years for a hospital appointment. But once we got that sorted, touch wood, we will have to think about how to actually dissolve the boundaries around this. That really requires us to think creatively around what are the challenges for our staff as well. I talked earlier on about the telemedicine briefly. It's quite difficult for people to move around organizationally or practice-wise. Okay, training, retraining, reskilling. So we need to think more creatively around how do we do this.
Mm-hmm. So a lot of changes are needed. And in one of your slides, you mentioned that one thing that is also needed is innovative leadership. Where do we find these new kind of leaders? Should they be healthcare professionals or not?
That's a fascinating question, and I'm inclined to ask you how many health med clinicians are in the room before I answer that question. But please don't throw anything at me. But I think I think most of our clinical staff will have to move into leadership positions. I think that is the case, and they will always be supported by some management staff. It will always remain the case, but we need to have the clinical leader more and more and increasingly. And I think we already moved on. We have now for 15 years talked about the hybrid professional, the sort of like clinical and management leader. But the important thing is to understand this is a complementary kind of like and the partnership really between managerial staff, between our management and the clinical staff. So it is hybrid roles. Our roles are changing, and clinicians need to take responsibility and need to lead as well. So that would be my answer. It's very diplomatic.
It's a good answer. And just briefly, this is my last question. How much do you personally rely on AI? Do you see it as a game changer?
Yes, AI. I haven't talked about. I don't know recently if you talked about this, but actually I can tell you. I think early on I flashed up. I'm running a company, healthcare analytics. I moved all my staff to AI solutions. There's practically in quantitative analysis, everything is done with AI now. So if you're thinking, let's sit this out, let's see what happens, forget about it. It just won't go away. We'll have to embrace it, we have to change it, and we have to work with it as best as we can. And of course, there are ethical dilemmas in this. I do recognize that. But the efficiency are enormous. I can just one thing. If you're running, I'm a data analyst, if you're running a data set with about 200,000 patients in a data set, it will take you several days to clean the data, to analyze the data, etc. With AI, it takes several minutes. These are efficiency you cannot achieve with human beings. So we have to embrace it, we have to work with it.
Thank you so much, Axel. It was a pleasure.
Thank you so much.
Thank you.
Thank you so much.
Thank you.